Next meeting, is it next Monday?
No, I'll find it.
I think we're live, everybody. Well, great. Good afternoon. Good afternoon on the East Coast. Good morning on the West Coast. And good morning in the afternoon to everybody else in between. Welcome to this week's edition of Live with Just Us, powered by Just Leadership 2.0, our national criminal justice reform organization committed to cutting the national prison population in half by 2030. I am your host, Ronald Simpson Bay, the Director of Outreach and Alumni Engagement USA. We thank you for your time and your support of this program and of our national efforts. We have a powerful program for you guys today. I'm sure that you're going to enjoy it. So before I introduce our guests, allow me to give you a brief overview of the aims, the goals, and objectives of our show today, and highlight our national Just Us campaign, which seeks to address the issues of COVID-19 in our jails and prisons across the country. At Just Leadership, we feel that without emergency management plans in place, we are doomed our incarcerated loved ones to illness and death. At Just Leadership USA, we have vowed that our incarcerated loved ones are not disposable, and we will not be ignored during this pandemic or any other future emergency crisis going forward. No one deserves to die behind bars due to the COVID-19 situation and the ineffectiveness and irresponsibility of our policymakers to act. COVID-19 has been unleashed upon our community, wreaking havoc in the country's correctional facilities. Since this pandemic began in March, more than 70,000 people in correctional facilities have been infected, and over 600 have died due to complications from COVID. Let's put that in perspective real briefly. In the last 10 years, the United States has carried out 321 executions, but the COVID-19 has killed over 600 people in just 3 months. And even worse than that, none of the over 600 that had died from COVID got the opportunity to say final goodbyes to their loved ones because of the isolation. This is not the first time incarcerated people have been at risk during a natural disaster or man-made disaster for that matter. In fact, federal and state officials have emergency planning in place for anything from floods to hurricanes to heat waves. Yet there are no proactive plans in place to save the lives of those detained. The alarm should have been sounded long before COVID-19. We can all recall the images of Hurricane Katrina, where the incarcerated people were herded on the bridge and overpasses to escape the rising flood waters at the last minute because there was no evacuation plan for people in place. While at the same time, they had an evacuation plan to evacuate the cats and dogs at the Humane Society. That's unacceptable and it's reprehensible that our policymakers have had a gross lack of foresight at such a high level of apathy when it comes to the care and attention to protect our people in prison and jails during this crisis. And all the ones that have been predicted or preceded it. This refusal to save lives, most of whom are disproportionately Black, reflects the idea that we are disposable. People in correctional facilities are mothers, fathers, teachers, brothers, and community leaders. They are human beings, and their lives, like all lives, matter. So now let me turn to the true pleasure I have of introducing our esteemed panelists we have here today for you. I would like to first introduce Sheldon Mcelroy. Sheldon is a personal friend of mine. He's an alumni of Just Leadership Leading with Conviction program. He graduated in 2016 from the program. He is a recipient of the 2018 Be Me Genius Award. Sheldon is an actor, a writer, an artist, a photographer, and a poet. Sheldon holds a master's degree in mental health counseling, and he is currently studying for his PhD at Duke University. Dr. Elise Wursel. Dr. Wursel is an MD. She is an assistant professor at the Division of Geographic Medicine and Infectious Diseases at Tufts Medical Center in Boston, Massachusetts. And she also works inside the Massachusetts County jails doing both SUD treatment and infectious disease work. and we definitely love the work that she does on behalf of the population. Dr. Mark Stern. Dr. Stern is a primary care physician and general internist specializing in correctional health care. He serves on the faculty at the Schools of Public Health at the University of Washington, Seattle, and at the University of Albany. Dr. Stern is the former Assistant Secretary for Healthcare at the Washington Department of Corrections, where he led the conversion of the state's prison healthcare system from a decentralized superintendent-run system to a single centralized system under physician leadership, and that leadership was under him. So I am proud to welcome our panelists. I'm proud to have them address us today. And this time I would like for them to introduce themselves to you. Sheldon, would you mind going first?
Yeah, thank you, Ronald. Thank you for the introduction. Thank you for your commitment to paying attention to the least paid attention to. That's people imprisoned during COVID-19, this pandemic, but also your deep commitment as a JLUSA fellow and as a leader in the organization of Just Leadership USA, always thinking about the impact of mass incarceration systemically, and always elevating and amplifying the voices of those of us that have actually been directly impacted. I'm really honored to be on this panel. As Ronald introduced me, I am a person with lived experience of incarceration, and one of my most vivid nightmares throughout my tenure of incarceration was to die in prison. And once a person became sick of even the most minuscule illness in jails and prisons, there was little to no chance of medical attention and a healthy recovery for multiple reasons. And so I'm really grateful to be on this panel. Thank you.
Thank you, Sheldon. Dr. Worsel?
Yeah, again, thank you for inviting me. And I've been working in the jail system for about 20 years. And it's important to me to try to give the quality of healthcare to people who are in jail that they deserve, which is this standard of healthcare that they get into the community. I strive to do that. And as an HIV doctor and an infectious diseases doctor and someone who treats substance use disorder, there's a lot of barriers. And I am trying to partner with key stakeholders like the sheriffs and people on the inside to identify these barriers and to work together to make them better. But I want to full-heartedly come on here and say I acknowledge that things could be better, and I'm hoping to make it better. In Massachusetts, I started being the liaison, the infectious disease liaison to all jails, helping to prevent the spread of COVID, to mitigate and to protect people. I hope to share some of my thoughts and experiences about this. I think more than anything, this illness has unmasked health disparities, which many people already knew existed, but this one, now we know. I mean, there's no need for more research almost. This is done. There are health disparities in accessing healthcare throughout America that are based disproportionately fall in Black and Brown communities. So I hope I can answer questions related to how best to protect people in jail, and anything about the infection and vaccines and things like that.
Absolutely. Thanks. It's such an honor to have you. Thank you for that. And last but not least, Dr. Mark Stern. Dr. Stern?
Well, it's a pleasure to be here also on the panel with Sheldon and Elise, and to be doing something with Just Leadership USA. I'd not known much about you guys before, but it sounds like you do wonderful work. I think we as physicians and professionals need to do more work with grassroots organizations. So as you mentioned, I'm an internist. I've been in correctional healthcare for about 20 years, started as a jail medical director in Albany County, New York, and then came to Washington as the medical director for the state system. Ronald, you asked me to tell the story of how I migrated from being the medical director to doing consulting and teaching and research a few years ago, and that while I was medical director, there was an execution that was scheduled, and unbeknownst to me, the lethal injection medications were obtained from one of the pharmacists, one of the staff who worked for me. And so essentially they came from me vicariously. And I went to my boss, who was the secretary of the department, and asked for the medications to be returned to me so that they were not being used in the execution. As many of you know, ethically, a physician and healthcare professional cannot participate in an execution. It has nothing to do with your moral position, has to do with the ethics of the profession, that we're there to care for people and help them live better, not to kill them. So unfortunately, the secretary refused to return the medications, and I was left with the situation of I needed to recuse myself from anything connected to the execution. And unfortunately, the only way I found to do that was by resigning. So that was in 2008, resigned from the department, and since then I've been working in corrections, in jails, prisons, in ICE detention. And the focus of all of my work, very similar to what Dr. Wursell does, is to improve patient safety for those who are incarcerated. You're sent to jail or prison as punishment, but it should not be for punishment, should not be a death sentence. And unfortunately, I see too many cases around the country where the quality of healthcare is poor and people suffer as a result. They're already suffering by being in prison, but you shouldn't have to suffer further by losing your life or losing your health while you're there. So that's the focus of my work. And I'll send it back to you, Ronald.
Thank you, Dr. Stern. Let me first give you a round of applause and congratulate you. A leader with conviction, courage, and morals. You could run a class for some people that we know in the White House. Thank you for your contribution.
Thank you.
And I think that leads me kind of to my first question to start our discussion off, and that's around why has the response to COVID-19 been so sad or so bad in our jails and our prisons? I mean, what, in your guys' mind, what is the main factors that threatens the medical safety of the patients in our jails, and what are some of the barriers?
Elise, you want to go first?
Yeah, I mean, I think this illness took everyone by storm, and even very prepared places like hospitals weren't prepared. And I think there was just this original feeling like hopefully it won't get there, which in retrospect is just ludicrous, that COVID wouldn't get into jails and prisons and be spread be spread in prisons. So I think it was almost like wishful thinking that, oh yeah, from an infectious disease point of view, we heard about Ebola and we heard about SARS, and that we were worried, but then it came. And I think one thing that I've been doing in Massachusetts is trying to really partner with the sheriffs and with the corrections officers, because truly the jail and the prison the prison system were not created to prevent or treat illness, but that's what they do. That's what they're charged with right now. And they have to work really hard to do that appropriately and correctly. So I think one, there was some thoughts that it just wouldn't happen. This would never happen, and we basically caught on too late. And the jails, as much as we all tried to work together, it just spread like wildfire. I think the nature of the virus is that it spreads asymptomatically, which is really different than a lot of other viruses that we deal with. And then the second thing being that, as much as doctors want to provide healthcare and we want to provide healthcare, quality healthcare, the jails mission was set up for something that the jails and prisons are providing healthcare, and sometimes they are not prepared. In some cases, in some places, they're just not prepared to deliver or prevent disease.
Right. That is definitely what's going on around the country. And I'm curious, Sheldon, as somebody who's been directly impacted, and the community that you and I work with directly, the people that are in jails and prisons, or maybe just coming home, what from your perspective, what has been, the same question? Why has the response been so bad in our jails and our prisons?
Yeah, I thank you for that, and I'll apologize in advance for my signal if some of my comments get skewed. Thank you to the doctors. I take no qualms with her perspective. I think that the perspective of those of us that have been impacted by incarceration is oftentimes with less patience. I feel that it's a more insidious reason behind why there's been little response. And I think it just really filters into lack of caring, lack of concern, lack of attention to those of us that are what society has deemed the least of us. I think I've seen remarks community-wide, that people incarcerated are getting what they deserve, right? That we earned being incarcerated. And so, if something as devastating as COVID happens, then that's just rightly what we should receive. And so I'm less inclined to see specific barriers as I am to see the culture and lack of concern for people impacted by incarceration.
Ronald, if I can.
Sure. Jump right in, Doctor.
So I have seen, and I totally agree with the description of that Sheldon just described of some jails and prisons. But I want to make sure there's a voice of hope in some of the things that work well. Elise and I have been working very closely with jail and some prison, but largely jail administrators over the last several weeks. And as Elise alluded to, jails and prisons are one of the few places where doctors and nurses practice that the mission is not healthcare. The mission is public safety. We have to deliver good healthcare, but it's not the mission. The military is another place where the mission is not healthcare, but you've got to have people who are taking care of our military. And there have been some bright spots in the last few months, and we've seen them in Massachusetts, where Dr. Wirsell is. I've seen them here in Washington. National Sheriff's Association reached out, as did Massachusetts and Sheriff's Association, Washington Sheriff's Association, because these are folks in the jails who realize that's not their mission. They don't understand healthcare, and they wanted to understand it. And I think we've seen some evidence around the country of some jails doing a very good job of decreasing their population, keeping people safe. That said, there are many places where that's not happening, and where, as you implied, we were caught by surprise and we're not doing a good job. And I would say the underlying reason from my standpoint for that is not so much about COVID. It's really what our state of preparedness was not preparedness, but our state of healthcare delivery in jails and prisons to begin with. I think there are some bright spots again, but there are far too many jails and prisons that don't provide good healthcare. And if they didn't provide good healthcare, if they were strapped for staffing and finance and materials before COVID-19, they didn't have much of a prayer when COVID-19 hit. Ronald?
Yeah, thanks for that piece, Dr. Stern. I mean, that segues perfectly to the next question I was thinking about asking. By you being an administrator and overseeing a whole system in Washington previously, I guess me and the audience, we'd be interested in hearing what measures do you think will help keep people safe? I mean, what hasn't been working, and who are the people who should be making these decisions for incarcerated people?
Well, I think you and I talked a little bit about it in prep for this session, and I'll share it with the audience. There's three underlying reasons why healthcare is insufficient, and among other things, why their responses to COVID-19 may be insufficient. Are number one is money, number two is money, and as you might guess, number three is money. I strongly believe that places that are struggling are underfunded, that we don't spend enough on healthcare for those who are incarcerated. And I'm not saying that we need to provide a Cadillac well beyond the quality of care that citizens receive. What I'm saying is that we're spending, I believe, in places well below the minimum level of what we would spend for the same individuals for their health care when they get out of jail or prison. And so if you don't have enough money, you get what you pay for. You can't deliver good health care. And whether it's decision making by the doctor, or whether you don't have enough nurses, or whether you don't have enough testing supplies, it all comes back to, unfortunately, money.
Absolutely. Money, money, money. And to that point, Dr. Wursell, I'm curious to know, from your perspective, what are the barriers to testing in jails for those incarcerated people who test positive? How is this a disincentive for them to seek testing, and how can we overcome these barriers?
Yeah, I think, well, first I just want to, acknowledge everything. I mean, Sheldon, you're the one with lived experience, and I'm coming at it from a different view, and I have a lot to learn. So I'm just going to lay that out there, and thank you for, I want to learn more and do better. I think one of the hard parts about this virus is it's so infectious that you need to isolate people in order to stop it. And unfortunately, when we think about isolating people in jail or prison, historically that's been to punish, either because of a fight or something has gone wrong, or, I don't want to get into a lot of reasons, a lot of things go on to isolate people. Isolation is a terrible thing, has severe psychological and physiological consequences. So when people are going into jails or prisons and they're pleading or asking with people who are incarcerated, if you have symptoms, let us know so we can test you. There's a lot of disincentives for people to raise their hand and say, oh, I'm kind of not feeling well. And I think this goes back hundreds of years with layers of distrust of, why would I raise my hand to be medicalized? I don't want your help. I'm scared of what's going to happen. So I fear right now, first of all, I can say, as someone being tested for COVID, the process hurts. It hurt me. I mean, I got over it, but you're asking people to be tested with a process that hurt. And I was just in jail this morning, and I wanted someone to be tested again, and he said no the second time, and I'm not surprised by that. So the test hurts, but I'm hopeful that soon we're going to have saliva testing, which will make that a lot easier. And so people will just be able to spit in a cup, and I hope that'll come within the next 3 months. The second thing is, if you test, even during the period of waiting for your results, it means you will likely go into isolation. And what that might mean, it means different things at different places. I know at a lot of the jails that I work, when you go into isolation, you'll get a tablet or an iPad or some way to deal with the psychological impact of isolation. But in other places, it means really cutting off all ability to communicate with anyone, losing privileges to phone calls, losing commissary. So there's tons of disincentives right now for the symptomatic people to get tested. That's why I'm trying to work with the sheriffs in Massachusetts to think innovative of how do we really make low barrier access to testing. I understand why people don't want to get tested in jail. So that whole system of offering testing for COVID needs to be revamped. There needs to be, I hope we can figure out a way to do like a medical isolation versus other types of isolation, and figure out ways to help people get through the period of quarantine, which can have severe psychological impact.
Wow, that is so eye-opening and impactful. I mean, we know it, and we know it in our hearts and in our minds, but to hear you explain it from someone who actually provides services gives us a much more clearer lens for me. And I guess to that end, Sheldon, you just heard Dr. Wursell kind of explain what the challenges are in providing the services. And I guess I would ask you, Sheldon, in your lived experience, what does it mean to get sick with limited access to health and medical at behind bars? We know the challenges of that, but could you help share with our audience what's it like?
Yeah. So a couple of things I think happen once you're sick in jails. I think, Doctor, you just spoke toward the disincentive of actually raising your hand if you're sick. It's discouraged by the corrections officers. And then you also have in male jails, you have, masculinity that, would encourage one socialized to not reach out for help. So there's a lot of barriers to being sick and in jail and accessing which is extremely limited healthcare in terms of, as both doctors alluded to, the lack of resources. I will say in this case, though, a lot of organizers in the very first weeks of COVID, there were nations outside of the U.S. that had COVID and had to de-incarcerate, and they wrote about it in length. And so America, we actually had an opportunity to take some best practices and implement them that would have been extremely cost effective. And we've seen this happen previously in this past decade, where financially it was not beneficial for states and municipalities to incarcerate at the level that they had. So they put forth specific goals to reduce incarceration as a cost savings measure. And so a lot of us organizers actually wanted a COVID response that would have reduced jails and prisons to the ability that people could actually distance at 6 feet apart and have the proper PPE. And then we also beg to argue that public safety should also include human beings that are actually currently incarcerated as well.
I'd like to amplify something that both Sheldon and something else that Dr. Wursell said. I think Dr. Wursell hit on probably the biggest barrier, which is the fear of being put in isolation. There's another factor that goes back to what I mentioned earlier about the underlying problems with healthcare, and that is that what I've heard from some people is, I don't have faith in the healthcare system already in my jail or prison. And so forget about the isolation piece for a moment, which is very important, but I just don't trust them. I don't trust the nurses or the doctors to do something in my best interest, so I'm not going to agree to be tested. Another barrier, which actually outside of the jail and prison system, is the connection with local health departments. This pandemic and control of it is so dependent on what happens locally. Even if you have a system like the Department of Bureau of Prisons or Immigration, that's part of a national system, but what goes on in an immigration center, for example, here in Tacoma, in the Northwest Detention Center, is a lot more related to what's happening in this community than is what is happening nationally. And that requires a close contact with the local Department of Health. And unfortunately, we haven't fostered a system in the years leading up to today where public health departments and jails and prisons work together. It just hasn't been part of our vocabulary. And then the last point I want to make, coming back to what Sheldon said, and I think that's so important, and Dr. Wursell touched on it too, is that perhaps the most important thing we could have done and could be doing to control the epidemic in our jails and prisons is downsizing. Getting the population down so that we can have that distancing. I mean, you can't have distance when you have 100 people crammed in a dormitory. It can't be done. And I think that, again, a positive is that I think nationally our jails have done a better job of downsizing. I know here in Washington State, some of the jails have gotten down to 60 or to 50, 40% of their occupation or of their original size, which is really great. The prison system, on the other hand, has not nearly done as well. And as Sheldon described, there's some countries that did that well. We are not doing it well. We're releasing handfuls of people from prison, but not nearly enough to allow for good social distancing. Ronald?
Dr. Stern, I'm glad you brought that up, because one of our missions is to, reduce the prison population, and through a number of means and by, a number of ways. And you kind of touched on and talk about this pandemic and the response. I guess I'm curious to hear a little bit more of your thought. Could you expand a little bit more about your thoughts around, reducing the prison population, and maybe some ways we could do it through, as a medical healthcare professional, it's my understanding that, from your perspective, what would you suggest to the administrators and the powers that be in responses to a pandemic such as COVID or any emergency management situation? What should they be thinking from a medical perspective and the challenges in reducing these populations?
I think that's a great question. It's certainly one that Dr. Wurtzel and I have been dealing with, I'd almost say nonstop, for the last few months. What we have to do is think differently. The decision for whether or not to let somebody out of a correctional setting, jail or prison, has always been one of public safety. What's the risk that they pose to other people by hurting them? And also, especially in jail, what's the risk of them not coming back for a hearing? That's what's considered public safety factors. And in COVID-19 days, we have to expand what we mean by public safety. Public safety is not just about, is this person going to hurt somebody if they get out, or are they going to harm property, but do they pose a risk to the public and to the public safety by not being let out? So you have, as everybody knows, if there's somebody in prison or jail who is at risk for serious complications from COVID-19, somebody who's elderly over the age of 50, and by the way, we use a lower threshold for calling people elderly in jail and prison, because people happen to age more quickly in jail and prison. We have, all of us have our theories, but so we need to use a lower number when we talk about aged people. But even beyond those folks who present a higher risk of catching COVID-19, of having serious complications from COVID-19, anybody in the jail or prison can get it. And because officers and other staff move back and forth to their community, they can become infected, and then they take the infection back to their community, their friends and family. And so when we try to make that decision of what is the public safety consideration of letting somebody out of jail or prison right now, it needs to, that calculation, that consideration needs to not only look at criminal issues, harm to individuals or property, but it also needs to include that public safety piece, which means we may be letting people out who do pose a little bit of a risk or are at the tail end of their sentence. So really coming back to your core question is of what can we do and what can the people listening do, is I think it requires us to put political pressure on the decision makers, whoever that is in your locality. Is it governor, or is it the legislature? Is it judges? To say, let's rethink how we make release decisions. It's not just about harm to property and people, but it's also the harm to people by not letting these people out, because COVID-19 will spread more quickly in our community.
That is powerful. I'm glad you brought that piece up around putting political pressure on our politicians, and we're gonna touch a little bit more about that in a little bit around what our listeners, our audience, can do to help put pressures on them. But at the moment, Dr. Wurtzel, I would like to hear, do you have anything that you'd like to contribute? I'd like to hear your thoughts on this as well, because you work in the jail setting. So what do you think are some of the measures or the challenges that we should be thinking about as far as reducing the jail populations?
Massachusetts, most counties were able to reduce the population in the jail, and that, I think, really, and decarcerate, and that really helped us control or minimize the impact. So I think that was the number one reason we were able to do okay. People who were in a pod setting or in a dorm setting were able to be given single cells. And we were really only able to do that because capacity was down. I think from from a data point of view, it'll be really interesting, right? Because there's all these people that we have let out early, and to see what the crime rates look like and what happens in terms of being reincarcerated. Because if we look at the numbers, we're going to, I think, find evidence that a lot of people that we let out that we were concerned about either did not commit a crime again, or these crimes that were committed were more related to the overall poverty of the community in the setting of COVID-19. So I would be a big proponent of communities in which there was really good decarceration or some decarceration, looking at the numbers of crimes committed and using that as evidence for other communities which didn't. Because if the concern is that people are going to commit crimes again, we can use data to convince people. And data, as much as some people in the White House don't believe it, is very powerful. So that would be my suggestion to communities that can rally the troops and the statisticians and the epidemiologists and say, well, this is when decarceration happened in certain communities, and this is what the crime rates were, and there's your evidence that these people didn't need to be incarcerated to begin with.
Wow, that is powerful. And that's perfect, because I'm thinking I want to pivot to a mental health discussion briefly. And you talked about data. And for those, I mean, you guys in the medical field, and at the time that, back in the late 80s, early 90s, they defunded community mental health programs. And there was a direct correlation to the defunding of mental health services in our community to the rise in the prison population in the late 80s and early 90s. So now, as we address this whole issue around, who's safe and who's not safe to be released during this pandemic or any particular emergency, how do we address, the mental health aspect of those that's in our jails and prisons? Dealing with them in there and releasing them at the same time. Because what happens, and what I've seen happen, is when the Department of Corrections, they won't tell the people, they won't tell in their numbers that the people that recidivate have high mental health issues. They'll just lump them in with everybody else and paint everybody as dangerous. While at the same time, we know the mental health is like it's a crucial, specific driver. So, what's your guys' thoughts around the mental health process and this whole pandemic? Anybody?
So, substance use disorder, at least in my neck of the woods, an opioid use disorder, it's a disease. It's a disease just like diabetes and a lot of other things, and it deserves treatment. And so it would be interesting to know when people are coming back in, everyone's getting tox screens, and if people are using drugs, it's a disease, and I think that needs to be subclassified within people who are coming back in. I can say in the setting of Massachusetts, we did decarcerate pretty rapidly, and a lot of people had struggles getting on buprenorphine or methadone or their substance use disorder treatment. And I personally lost a few patients who overdosed and died afterwards. The world was shut down, and so for the most privileged of us, we could get Instacart. But for the rest of the world, things like insulin and CVS's and these sort of everyday things weren't happening. So I guess to your question, I would love to know, would people with schizophrenia, when they commit a crime again, this is someone with an illness that deserves treatment, not punishment. And I do think it's worth finding out how many people who are reincarcerated did so because they had marijuana on their urine tox, or buprenorphine on the urine tox that was, prescribed. There are all these different things that I have seen people be reincarcerated for, which we would argue is not a crime, it's an illness.
Absolutely. Absolutely.
Our problem our problem, as Dr. Russell is alluding to, it started before COVID-19.
Yes.
We essentially use the criminal justice system to treat drug abuse and mental illness.
Yes.
It's kind of what you were saying before, Ronald. It's just crazy. It's just nuts. And some more progressive places have started to have good diversion systems where people who have a behavioral change because of substance abuse or mental illness, instead of that being criminalized, it's medicalized, which it is. It's a medical problem, and it should be treated not with incarceration. We don't do that well. And so, you have that underlying problem, then we just added COVID-19 on top of it. And so a system that wasn't working before, it can't possibly work well with COVID-19. We've both, Elise and I, have seen examples of people being released, I almost say prematurely, or being released as a result of COVID-19, but not having adequate safety nets and pieces in place to be able to take them safely into their community. I'm going to just pivot to one other thing that Elise reminds me of, and this is also part of the underlying system, specifically around opiate use disorder. One of the laws that was in one of the federal rules in place is that to treat somebody with buprenorphine for an opiate use disorder, their first visit has to be in person. And there are a lot of jails around the country that just don't have the physician in there. Some of them very small, they don't even have a physician, period. And they want to do the right thing. They want to just begin the person on buprenorphine, but they have to go see a buprenorphine provider in person. They're not allowed to do it by telemedicine, which is just such an easy solution. Fortunately, the federal government has relaxed that requirement during COVID-19, which has helped us deliver some opiate abuse care, but that rule may go back to the way it was later. So once again, coming back to advocacy and what people can do in grassroots would be to encourage the government to keep that rule in place even after COVID-19 is over, and say, hey, if you've got an opiate use disorder, the doctor thinks you should be on buprenorphine, that we can just get you on telemedicine, FaceTime, whatever, with the doctor in the community who provides it, and get you started now before you leave jail.
Yeah, thank you for sharing that, Dr. Stern. And as I go to Sheldon for a comment, I would like to remind our audience, if you have questions, feel free to type them into the chat section, and we will try to address your questions as we move forward. And Sheldon, one thing that we didn't reveal about you was your amazing work in the National Bail Project that you've done for a number of years. And I want to salute you and give you credit for the work that you did to try to eliminate cash bails, not just locally, but nationally. And so I'm curious, I guess I'm just, as a kind of a thought came to my mind in dealing with people that on bail and pretrial status, what have you. Did you have any type of issues around, determining the mental health of people? Or how did that come into play in any of the decisions around bail?
Yeah. Thank you, Ronald. If I can also, I'll answer that question, but I'll also kind of lean back into my first statement about the lack of concern. I know Dr. Stern is in Washington State, and when we were working with the jails in Spokane, we were reached out to by the corrections union. One of the comments in our comment section is about corrections unions. And so my theory about the de-incarceration in a lot of places that are doing it well is that it's less about the people inside and it's more about the workforce that does not want to be jeopardized by the threat of the virus inside. And so the ones that are doing it well, I believe, because in my own work, we coined a letter on behalf of a corrections union that would go to policymakers. And it was interesting to find unlikely bedfellows writing a letter to reduce jail population that in a lot of worlds would have been advocating for the construction of new jails as a means of economic development and to expand the current state of not only their unions' access to more employable opportunities, but also to the community utilizing jails and prisons as an economic developer in those communities. At the work that I did at the Bail Project, my last day was Friday the 17th, actually. So it was pretty recent, and we were working to reduce population of pretrial incarcerated people. These are people that have been convicted of nothing, accused and are being held. These people are even found guilty of nothing, are being infected with COVID in jails all across our nation. And our response, we can't hide behind public safety in that regard. We don't have, we have this assumption that people are innocent until proven guilty. However, in some cases, we are jeopardizing their entire livelihood because of the inability for them to distance and have PPE access. And so, but to the point about mental health, you know, not in jails, but nationally, 75 to 85% of folks incarcerated in the United States, mental illness, substance abuse, and some kind of health issue. So we are in a world where we use institutions for those purposes. And it's devastating when you mix that use with the pandemic at the same time. You get these collateral consequences that we're suffering from right now. Our vision around reducing jail populations is to go back and form reductions, jails, and prisons.
Thank you, Sheldon. We're starting to lose your signal, so check your connection while I pivot to Dr. Worcel. I would like to get some parting thoughts, some final thoughts from each of you around, you know, what's your thoughts, and going forward, what would be some suggestions you would have, you know, for addressing this pandemic and for our audience?
I guess one thought is to think about the type of masks that are being distributed in jails. I think it's not everyone knows that not all masks are created equal. And I think there should be more investment in surgical masks provided to everyone rather than cloth masks. And I think, like Dr. Stern mentioned, you know, cost, but this is an investment that's worthwhile, and people are obviously deserving. There's no question in my mind that everyone should, as much as possible, have a surgical mask, because if you remember, a cloth mask will prevent you from giving it to anyone, but it won't necessarily prevent you from getting it. So if everyone's wearing cloth masks, I guess that works out. There are some places in which the COs get surgical masks, and the you know, people who are incarcerated get cloth masks, and I think that sets up a really negative. It's not great to see that, because I think that shows some preferential valuing of lives, and I hope we can work towards that. And then I think planting a seed. I want to talk about, you know, vaccination. As vaccines get developed, we know, because of past transgressions, people who are incarcerated can't be involved in those current vaccine studies, even if they're the most at risk. So I'm trying to work to try to see how to engage people in the community and how to get the word out. So thinking now about, well, if we have a vaccine, who's going to get it, who's going to want it, who's going to need it, and start thinking now a year ahead, 2 years ahead, because vaccination is a way we protect ourselves. But if healthcare isn't going to trickle down, it doesn't trickle down, then we know vaccination will not get into the incarcerated setting. So I think that's something we need to start thinking about now.
That's a great thought. And yeah, I hadn't even thought about the vaccine part of it. Thanks for bringing that to our attention and lifting that up for us. Dr. Stern?
So 3 things come to mind. First, I'm going to pick up on Elise's comment about vaccine. I think what she described as the first and most important thing is that we need to be sure that it's accessible to the jail and prison population. We get forgotten. But once it gets in there, one of my other fears is that because the population is untrusting of the healthcare system in jails and prisons, that we may find a lot of resistance to having the vaccine. And I think that's a place, again, where your listeners could play a role in helping to figure out, how do we get that message? How do we make people who are incarcerated comfortable and not fearful of the vaccine? That is going to be important. The second thing is that we need to continue to work on depopulation during the COVID-19 pandemic. And so I would call on listeners to find out locally, what's the state of their jail or prison? Has the size gotten down significantly? And if not, be pulling all of the political strings that they can to continue the depopulation. And then the last thing is about lessons learned, and that comes back to the bail situation and what Elise mentioned earlier about using data in Shelton's project. And so here's a great opportunity. Well, a lot of jails, a lot of judges and prosecutors, and I know in her neck of the woods and in mine, got away, markedly reduced bails or got rid of it. And so we have a natural experiment that, as Elise said, we have the data. We can go back and look at and say, what was the effect of getting rid of bail? And if we discover this, I think we all suspect that it won't have much of a difference. There's a wonderful lesson that we can take going forward.
Wow, that is certainly food for thought. And I would hope that our listeners would, take your advice, Dr. Stern, and see what their jail populations are and work, comparatively speaking, and put pressure on their legislative representatives to actually address it. Sheldon, you want to give us a final comment?
Yeah, I mean, I think to everybody's point, we need pressure from community members, medical professionals, and additional stakeholders to reduce. We're in a world where people are saying that, there's a need to defund not only the police, but institutions such as corrections. And that funding could go to mental health services in community, health services in community. And I think to Dr. Worcell's point, the data will show, and we've got, Ronald, we've got tons of data around de-incarceration well before COVID that supports, the Bell Project operated in the Bronx for 10 years. We bailed out 2,000 people. 96% of our clients returned to court, right? And so this idea that people aren't going to show up for court unless they have their own cash money, it's been debunked. Nationally, in the past 2 years, we've bailed out over 10,000 people, 88% of the people nationally. So in New York, it's easy to understand how a resource-rich city could bring people back, right? But nationally, in places as small as Baton Rouge and Louisville, Kentucky, and St. Louis, and all over the nation, our data has shown pretty true that if you bring people out, connect them to social services, mental health services, etc., that the likelihood of them reoffending decreases, as well as the likelihood of them attending court increases.
Absolutely. And I mean, that is so powerful. And the thing about it is that, the community in general doesn't know these things because they're being fed a whole different line of, what the narrative actually is instead of what the truth is. So I appreciate each and every one of you taking the opportunity to help educate us, educate our audience, and educate the community around our responses during this pandemic, COVID-19 crisis. We have a comment in the comment section from Kimberly Haven. She talked about the pandemic policy development, about the vaccination part of it. She thinks that first responders will be the first to get it. And she fears that incarcerated individuals will be at the bottom of the list. And these are also more likely to come from underserved communities. They will present with a greater risk need. And I think that, thinking that's kind of a mixed blessing, a curse and a blessing at the same time to, not be at the top of the list, but to be at the bottom. Because I'm remembering back in Michigan prison, they used to do trials on people incarcerated, and not all of them were very good. This was I'm thinking back in the 80s. But so there is some validity to what she's saying, but at the same time, I'm not even sure if I would want to be at the front of that bus. You guys got the doctor, as far as vaccination, you guys got any suggestions or thought about that?
Retinoic acid was developed in Holmesburg prison, and off on the backs of people that were, told it was research and really abused. And I think we have tons of things in our medical history that are despicable. So it's not going to be an easy discussion. But, when I look at who gets vaccinated for the flu, and I've actually been doing research in the jails, and so few of the people in jail get vaccinated for the flu, and so few of them get vaccinated for prison. And when you talk about it, they say, my mom said never to get it, or, I've never gotten the flu, or the flu vaccine gets it. But somehow the messaging in other communities, people take it. So we got miles to run on that. And I'm not expecting it to happen overnight. So yeah, we have a lot of making up to do.
Yes.
A lot of making up and apologizing and building trust and rapport. And I try to do that, but I could do it better. And I don't know, that's a huge point that needs to be done.
Thank you. Thank you for being thoughtful about it and lifting it up. Dr. Stern, do you have a comment you wanted to make before we close on that?
Yeah, I'm not so worried. I think about experimenting with vaccine on people in jail and prison. I think there's a lot of safeguards in place today as a result of all the bad things that have happened and abuses of prisoners in the past. I'm much more worried about low levels of two things. First of all, as Kimberly Haven said, of our not being prioritizing people who are in jail and prison, and then once they are prioritized, again from pressure from people on the ground, that they may not accept it because of fear. So I think those are two places where the public can be helpful, of making clear that we need to make it available, the vaccination available to people in prison. And one of the taglines, one of the things to remember as you talk to your legislators and your media, is it's not, even though to us the most important people are the people who are in jail and prison, their health. When we do things around COVID-19 and vaccination, it's not just about their health, it's about the health of the community. That we have to remind people we're also keeping the community safe, because it's so easy for virus to spread in a jail and then spread to outside the jail. So use that as an argument when you talk to legislators. And then the second thing we have to be creative about, and this is where I think it's so helpful to turn to people with lived experience, is how do we make people comfortable accepting the vaccine? That worries me.
Well, thank you so much. I would invite our audience to give our panelists a rousing round of applause. I appreciate the wisdom and information and the knowledge that each and every one of you share, because you come from very, very extensive and authentic backgrounds, and I'm sure our audience appreciates you as well. But for our audience, we would be remiss if we had an hour-long talk fest and didn't have a call to action for everybody. So at this point, I would kind of like to point out our Just Us campaign call to action. We at Just Leadership, with the arrival of COVID-19, for us, it exposed the systemic inequalities and racism in our criminal justice system. We have a responsibility to uplift the dignity and human rights of everyone. But we discovered that the lack of an emergency planning process in correctional facility is actually a violation of that responsibility. The country's commitment to protect the most vulnerable depends on us working together. And we ask that you work together with us around our Just Us campaign, which was launched last month. We call in on our legislators to enact proactive solutions to protect the human beings behind bars during this COVID-19 and other disasters. If you go to our website, jlusa.org, and click on the opening window, you see that we have outlined recommendations for immediate emergency preparedness plans for those in the criminal justice system. These policy recommendations could lead to potentially historic legislation in every state in our country. So if you go to our website and you click on the Just Us campaign, you're going to find a link to your local legislators. You don't have to even figure it out. We figured it out for you. If you click on the letter, we have a pre-written letter for you. And when you click on it, it'll tell you who your legislators are in your own area. Once you enter your address and your location, it'll tell you who your representatives are. And we would ask that you fill out that letter, complete it, and send it off to the legislators that indicated on our website. Because by neglecting the safety of millions of people incarcerated and trapped in our correctional facilities, our society, our elected officials, and those currently in power are showing once again how Black and brown people are treated in the United States. So we would ask each and every one of you to take just a few minutes to go and fill out that letter and submit it for us. And if you're interested in getting involved in a campaign in your community, we are actually doing campaigns across the country to help write legislation in various jurisdictions to help get this through. So we need your support. We need your assistance. If you have any interest, you can go on our website. You can contact me at ronald@jlusa.org. And I will certainly be glad to link you to our wonderful team who's doing this work across the country. And with that being said, we're at the top of the hour. Thank you, my beloved panelists. Thank you, my audience. And thank you, Just Leadership, for putting on such a powerful platform. I leave you all as I came. Peace.